much. I'd like to thank the organizers for the opportunity to speak at this very interesting meeting. I recognize that I'm in the unenviable position of being the person who stands between everyone in the room and lunch, but I will try to cover as much as I can in a relatively short period of time on this subject of acute kidney injury. And I take a little bit more of a cynical approach to the progress that we've made in the field of nephrology, particularly related to acute kidney injury, than what some of the other speakers have demonstrated have been substantial advances in the care of patients with diabetes and cardiovascular disease. So the title that was really proposed to me, assigned to me, was Trials and Tribulations in Acute Kidney Injury. Do we know where we're going? I think, unfortunately, a bit more of a relevant title would be Trials and More Trials in Acute Kidney Injury. We seem to have lost our way. And so what I'll do over the next 25 minutes is talk about the definition of acute kidney injury, the epidemiology and outcomes of it. I'll briefly touch on interventions, and I'll discuss why interventions in the field of acute kidney injury seem not to have worked. I'll give a little bit of information about what we can do as practitioners to try to attenuate the damage that can be done by acute kidney injury, and then where we're going in terms of future directions. So the definition of acute kidney injury has evolved over the past 15 years. For those nephrologists in the audience, you know that the initial definition was proposed by a set of criteria referred to as RIFLE. And that merged or morphed into the AKIN criteria, or AKIN. And the most recent iteration, which is really being adopted worldwide, is the KDIGO definition. And KDIGO is an organization of practitioners based in Europe that is designed to generate evidence and evidence-based guidelines for the management of patients with and at risk for various kidney diseases. So what the KDIGO AKI criteria are, they're based on changes in serum creatinine over various time periods and or changes in urine output over various periods. And there are 3 stages ranging from what is really referred to as mild acute kidney injury, moderate acute kidney injury, and severe acute kidney injury. And I'll present a case and explain to you why I think that these criteria have really led us in the wrong direction, and why I, quite frankly, have never used them in the care of a single patient in the past 15 years. So this is a 55-year-old man with no other prior medical history who weighs 150 kilograms with a serum creatinine of 79 micromoles per liter, who's admitted to the hospital and undergoes uneventful elective surgery on his foot. He remains in the hospital while the social work service arranges for outpatient rehabilitation. And on post-operative day 2, for reasons that remain completely unclear, he had another serum creatinine checked. And lo and behold, it was entirely unchanged, 79 micromoles per liter. Detailed ins and outs recorded a urine output of just a bit more than a liter over the past 24 hours. Per the KDIGO criteria, this patient has stage 3 or severe acute kidney injury. He has less than 0.3 milliliters per kilogram per hour of urine output over a period of 24 hours. And if you look at the literature as to what is going to happen to this patient or what his risks are, his adjusted odds for in-hospital death have gone up by just shy of 5-fold. Now, everybody in the audience recognizes that this person does not have acute kidney injury. This person has probably modest reduction in oral intake and or faulty ins and outs recorded in the hospital. Nonetheless, he met criteria for severe acute kidney injury. The definition of acute kidney injury that we're currently using, really in the research setting, has a specificity that is simply abysmal, particularly for urine criteria, but also for the serum creatinine criteria. In addition to that, the positive predicted value of small increases in serum creatinine for true kidney injury is very poor. Patients may have a very small increase in serum creatinine of 25 micromoles per liter and meet the criteria for stage 1 acute kidney injury, but simply have no evidence whatsoever of any true damage to kidney tissues. So both the specificity and the positive predicted value of the definition that we're using worldwide is very poor. Now, what about the incidence of acute kidney injury? Is this a disease? We've all seen it. Is it a disease that is decreasing by virtue of greater recognition of preventive interventions, or is it increasing? This is one of many studies, this one by Jeremiah Brown from 2016, that looked at the incidence of acute kidney injury in various age categories. And what he showed was that over a period of 10 years, from 2001 to 2011, the incidence, particularly in those between the ages of 45 and greater than 75, has skyrocketed. Now, these numbers have continued to increase over the past 5 to 8 years. Smaller increases in patients who are younger. Nonetheless, there still is, in this group of patients 20 to 44, an increase in the incidence of acute kidney injury. Now, what about outcomes of acute kidney injury? We've been tracking outcomes of acute kidney injury now for several decades. And this was a Canadian study that looked at the trends, the secular trends over time in mortality if patients develop dialysis requiring acute kidney injury. And what it showed was that, to begin with, between 1995 and 2009, the mortality rate per 100 patients has essentially remained unchanged. You've got approximately 40 to 50% of patients who develop dialysis requiring acute kidney injury in the hospital who are going to end up dying in the hospital. And that number has not changed as you move forward. In terms of the adjusted odds of death in the hospital, same thing. There has been simply no change in the adjusted odds of mortality for acute kidney injury that requires dialysis over a period of decades. So why is mortality with acute kidney injury still so high? Why is it essentially not changed in 25 plus years? The answer, I think, in large part lies with the complexity and the extrarenal effects, the effects of acute kidney injury outside of the kidney. And what happens in patients who have severe acute kidney injury, there are adverse effects on the intestines, the lungs, the brain. There are multiple adverse effects on the heart with myocardial dysfunction, and there are also abnormalities in the liver. In addition to that, there is an increased risk for infection with acute kidney injury and other extrarenal effects. So the fact is that we can clear toxins and remove fluid with renal replacement therapy. Dialysis is very effective at removing toxins and at removing fluid. And patients simply don't die of AKI, they die with AKI. And I believe that it is these extrarenal effects that is driving much of the mortality. Okay. So in terms of the definition, the current definition of acute kidney injury is highly problematic, and quite frankly, it's rarely used in clinical practice. It's used in research settings to compare outcomes and for prognostic purposes. It's rarely used in the clinical setting. Acute kidney injury is common in hospitalized patients. Unfortunately, the incidence is increasing, and the mortality is unchanged over decades. And that includes multiple adverse extrarenal effects. So let me shift now to what has been a couple of decades, really 3+ decades of studies that have looked at interventions or treatments for established acute kidney injury. And this is an attenuated or shortened list of interventions that have been looked at in clinical trials for acute kidney injury. And it includes dopamine, phenoldiprate, loop diuretics, ANP, insulin-like growth factor, thyroxine, alpha-melanocyte stimulating hormone, endothelin antagonists, erythropoietin, hepatocyte growth factor, activated protein C, adenosine 2A agonists, and alkaline phosphatase. This is a brief list of interventions that have been investigated in clinical trials. This is the list of interventions that have been shown to be beneficial. That's it. So why have studies to date not identified effective interventions for acute kidney injury? There really, in my mind, are two reasons. The first one is that AKI is very pathophysiologically complex. And the second thing is that I think we in nephrology, to some degree, have lost our way in terms of performing the kinds of clinical trials that have been presented this morning. So let me talk briefly about the pathophysiologic complexity of acute kidney injury. This was from a review a number of years ago describing the pathophysiologic processes, a basically simplified view of the pathophysiologic processes that happen with ischemia reperfusion injury. That is, clamping of the renal arteries and then release of the clamp, mimicking ischemic acute tubular necrosis. And what you have in this scenario, when you have this ischemia reperfusion injury, is you've got infiltration of macrophages and neutrophils. You've got upregulation of inflammatory cytokines, and this is all occurring in the kidney. You've got the generation of profibrotic factors early in the course of acute kidney injury. You have activation of the alternative and the classical pathways of complement system. And you have increased generation of reactive oxygen species. These are all occurring simultaneously in the kidney in the setting of ischemia reperfusion. So there are multiple simultaneous cellular and inflammatory processes that have made it difficult to identify a singular intervention that is able to attenuate damage. And this really is a different process, at least from a therapeutic standpoint, from an acute thrombus, which is treatable by a balloon and stent. We don't have a balloon and stent for the microvasculature and the glomeruli in the kidney. The second reason that I think we've not been able to identify effective interventions for the treatment of acute kidney injury is that we've conducted trials that have been poorly designed. And I'm going to go over 3 examples of trials that have been performed in acute kidney injury, established acute kidney injury. These are not preventive trials, but established acute kidney injury. And I'll discuss 3 different aspects of clinical trials that highlight methodologic flaws in the approach to the design of those trials. So insulin-like growth factor 1 is an anabolic polypeptide. It increases renal blood flow and increases GFR and has in preclinical studies. And studies in otherwise healthy rats demonstrated that it attenuated damage from ischemic acute kidney injury, and it also decreased mortality. So in 1999, about 20 years ago, Hirschberg conducted a clinical trial in Kidney International, which is one of the high-profile clinical journals. 72 patients with acute kidney injury were randomized to subcutaneous IGF-1 or placebo, and the trial tracked kidney function, the need for dialysis, and mortality over a 14-day period. In terms of the tracking of glomerular filtration rate, or GFR, over those 14 days, you see that there was essentially no difference between placebo and IGF-1, and there was no difference in mortality at day 14. So why did this trial not show a difference? This trial really highlights the problem with selection of the patient population for a clinical trial. So selecting the right patients for a clinical trial is essential. The animal models of IGF-1 upon which this trial was based looked at ischemic AKI. All of the rats had ischemic AKI. The Hirschberg trial included patients with other causes of acute kidney injury. In fact, more than a third of patients had septic-associated or sepsis-associated acute kidney injury, which really is a different animal than ischemic AKI. The animal models of IGF-1 looked at otherwise healthy rats. So they were healthy rats, they gave them ischemic acute kidney injury, and then they injected IGF-1. The Hirschberg trial, the mean Apache score was 25. These patients were sick. The third issue relates to when the intervention was implemented. So in the animal models, the IGF-1 was implemented very early on after the ischemic injury. In the Hirschberg trial, patients had a serum creatinine of more than 530 micrograms per liter at the time that the IGF-1 was implemented. Hirschberg's patient population looked absolutely nothing like the mice upon which the basis of the trial was established. And really, the potential role of IGF-1 in human AKI remains unknown. The patient population was simply the wrong patient population to study. It didn't match the preclinical and animal data in terms of identifying a potential benefit of IGF-1. Now, I don't know whether IGF-1 would be beneficial if it was looked at in the right patient population, but I know that this was the wrong patient population to study it in. The second issue for clinical trials in acute kidney injury relates to sample size and power. Thyroxine is obviously active thyroid hormone, and it has been shown in rats to reduce tubular defects in sodium potassium ATPase and alkaline phosphatase in the setting of nephrotoxic acute tubular necrosis. So a clinical trial that was done at my institution in Pittsburgh by AKI et al. Randomized 44 patients with post-transplant acute tubular necrosis to receive intravenous T3 or placebo. The T3 was started 12 to 24 hours after the transplant and given for 6 hours. The outcomes that they looked at were the percentage of patients requiring dialysis, the percentage of patients recovering kidney function, time to recovery of kidney function. And they looked at this both as a short-term outcome study and as well as a long-term outcome study at 1 year. In terms of the short-term outcomes, this doesn't project particularly well, but there were no differences between the control and thyroxine in terms of any of the outcomes, what the proportion who required dialysis, the duration of dialysis, whether they recovered kidney function, time to recovery, or overall length of stay. And at 1 year, no difference in graft survival, no difference in serum creatinine, and patient survival was completely identical. So what does this study teach us? It teaches us that sample size and power assessments are essential if one is planning a clinical trial, and also essential in terms of interpreting the significance of a clinical trial. So sample size is obviously derived from the estimate of a basal incidence of the primary outcome. You may not necessarily know the exact incidence, but you need to have a general estimate of what the basal incidence is of the outcome that you're looking at in the population. And it is also based on the estimate of the effect size of the intervention. How much will the intervention reduce the outcome that you're looking at? In terms of power, power is a function of the failure to detect an effect when an effect is present. For well-designed clinical trials, the power is typically set at between 80 and 90%, which means there is a 10 to 20% acceptance of a failure to detect an effect if it in fact is present. The AKI trial provided simply no estimate of the basal incidence of the primary outcome, and it provided no estimate of the effect of T3. They simply didn't describe it in the trial. It provided no information on the power of the study. They simply didn't discuss it. And so if you think about this hypothetically, if one were to try to design a trial of T3 and you assumed an 84% incidence of the primary outcome, 80% power, and a 10% absolute effect size. That is, you believe that T3 is going to reduce the primary outcome from 84% to 74%, you would need 950 patients. Their trial enrolled 44. So the ACR trial was not a negative trial. It was a trial that failed to find a benefit because of its methodologic limitations. And what I would argue is that based on that, the role of thyroxine in terms of treating established acute kidney injury has not been established. Again, I have no strong reason to believe that it is necessarily effective, but based on the trials that have been done of it, we have no idea whether it is. Lastly, I'll talk about the importance of primary endpoints in terms of designing and interpreting clinical trials. So dopamine, particularly in low dose, and phenoldiprem, which is a dopamine agonist, in healthy volunteers has been shown to augment renal blood flow. A clinical trial by Brienza et al. Enrolled 100 ICU patients with early AKI, and they were randomized to dopamine or phenoldiprem for up to 4 days. The primary endpoint was a change in serum creatinine over time. And what you see here is that phenoldiprem actually resulted over 4 days in a slightly improved reduction in serum creatinine. They started out at 1.99 milligrams per deciliter, and it dropped to 1.56. In dopamine, 1.91 milligrams per deciliter, and it dropped a bit, but not as much. In terms of the need for dialysis, no difference. So what is the issue with this trial? The primary endpoint was a change in serum creatinine at 4 days. And as Dr. Pfeffer pointed out this morning, surrogate endpoints are problematic. And certainly a change in serum creatinine, while we would like to believe that change in serum creatinine is clinically significant, the fact of the matter is that we don't know whether small changes in serum creatinine are in fact significant. Part of the reason for that is that there are multiple different things that can affect serum creatinine apart from a change in kidney function. Concomitant illness and liver disease, dietary intake, there are issues with lab variation and assay interference, medications, and certainly volume overload, hemodynamic shifts, and intravenous fluid administration all can affect serum creatinine in the absence of having any effect on actual kidney function. The primary outcome that was assessed in this trial was done at 4 days. Acute kidney injury is commonly much more prolonged. The mean difference in the serum creatinine of 26.5 micromolars per liter is of unclear clinical significance. The peak serum creatinine was in fact not different between the two groups, and in terms of a clinically relevant patient-centered outcome of needing dialysis, there simply was no difference. So what this use of a primary surrogate endpoint enabled was a small feasible trial of 100 patients that had absolutely no clinical impact whatsoever. A subsequent larger trial by Bove et al. In JAMA found not only no benefit of phenoldiprem, but potential harm. So those are examples of clinical trials that have been done and published in not insignificant clinical journals that have really not contributed to our understanding of how to prevent established or how to attenuate the damage of established acute kidney injury. There have been successful trials in the area of acute kidney injury. 2 of them relate to the use of renal replacement therapy. This is the ATN trial, and this is the Renal trial that were published in 2008 and 2009, respectively. They both looked at intensity of renal replacement therapy, slightly different ways. This one looked at both intermittent dialysis and continuous renal replacement therapy, intense therapy versus less intense therapy, and it showed no difference in all-cause death within 60 days. This was a trial of 2 different doses of continuous renal replacement therapy. It showed no difference in death at 90 days. But these were well-designed and well-conducted clinical trials. They happened to be negative studies, but they looked at a clinically meaningful single primary endpoint event of death, certainly patient-centered and patient-relevant. They had large or relatively large, in nephrology, these are large trials, they had relatively large sample sizes and appropriate effect sizes a priori. Before the trial was started, they estimated absolute risk reductions of 10% and 8.5% respectively. These were definitive trials which effectively answered the clinical question of whether more intense dialysis improves mortality. And the answer was definitively, it does not. Now, let me pivot now to one of the avenues that cardiologists have been incredibly successful at. Nephrology has lagged behind in terms of identifying biomarkers that can help us both identify patients who are going to develop a disease or who have early disease, and also enroll patients who are at higher risk for adverse outcomes in clinical trials. And so the question in nephrology has been, have we been able to find can we find the renal troponin? And this is the history of cardiac biomarkers, a very simplified history, but it goes back to the 1950s when AST and LDH were being used in patients with acute myocardial infarction, and then CK was introduced in the 1960s, and CKMB, and then cardiac troponin T and cardiac troponin I. And prior to the year 2000, there was point-of-care testing of troponin. Here's what we have in nephrology. We have blood creatinine and urine output beginning in the 1950s and going all the way through the current day. These are the two markers that I showed you were what we use to define acute kidney injury, and those are KDIGO criteria. Those are criteria that are accepted by an international organization. In 2014, a test called the NephroCheck was introduced, which is TIMP2 and IGF binding protein 7. There's a combination test that was introduced in 2014. It is being used clinically in some hospitals. I can tell you that in my hospital, it has never been introduced as a potential test. It does have some promise, but it suffers from several potential weaknesses, which I'm not going to get into. The long and the short of it is, at this point, we are identifying patients as having acute kidney injury based on their blood creatinine and their urine output. Now, there has been an extensive search for the renal troponin by multiple very accomplished investigators in nephrology. One of the principal biomarkers that has been looked at is neutrophil gelatinase-associated lipocalin, or NGAL, both in the plasma and in the urine. And here was a study, this was one of the very first studies of NGAL in 2003, and they identified it as a early urine biomarker for acute kidney injury from ischemia. This is a study from just this year. And it is looking at, again, 2003. They started looking at it 2019. This year, we're looking at whether it actually works in identifying patients with acute kidney injury in the critically ill. And I point out here, this is a 16-year period where we've gone from identifying something to trying to determine whether it actually identifies patients with acute kidney injury. We've made, unfortunately, very little progress in terms of identifying a renal troponin. And we're certainly in clinical practice, other than a few exceptions, there are a few biomarkers that we use to assess kidney function. We're still principally reliant on serum creatinine. So what do we know at this point? We know that acute kidney injury, the definition of it is highly problematic and really not applicable to clinical practice. AKI is common and increasing in incidence. Mortality is high and not improving at all. AKI is certainly pathophysiologically very complex. It's a multi-system disease. People don't die of AKI, they die with it. but certainly that complexity makes treatment incredibly challenging. Most clinical trials of AKI have failed because they've enrolled an inappropriate patient population, they've had inadequate sample size and statistical power, and/or they've used clinically irrelevant endpoints. It has been challenging to identify AKI biomarkers that can inform early diagnosis and treatment response. What we in nephrology clearly need is additional science on early disease diagnosis, on therapeutic targets, and testing of interventions in adequately powered, properly designed clinical trials. And so just a few years ago, the National Institutes of Health in the United States funded a multi-center project called the Kidney Precision Medicine Project, or KPMP. And this is really the NIH's acknowledgement that we need to go back to basics. The acute kidney injury, and this is a project that is spanning both acute kidney injury and chronic kidney disease, but for acute kidney injury, what they're doing is they're performing biopsies of patients with acute kidney injury, so renal biopsies of patients with acute kidney injury, and they're going to look at them to identify critical cellular processes, critical clinical pathways, and targets for novel therapies, trying to identify what's happening microscopically to try to understand how we can better design therapeutic interventions to target those processes. So it's really starting over. My suggestions in clinical practice are fairly basic, and I know for the nephrologists in the audience, we probably get quite tired, I know I do, of what we recommend when we're consulted for acute kidney injury. It's supportive care, avoid hypotension and nephrotoxic insults, and cross your fingers. Really what I recommend is minimize use of nephrotoxic drugs when alternatives are available, and there is a big opportunity to do this. We're still using nephrotoxic drugs in some instances when there are alternatives that are comparably effective but are less nephrotoxic. I think it's important to anticipate high-risk situations and avoid concomitant nephrotoxic insults. Much of AKI is multifactorial. There's not necessarily a single isolated insult to the kidneys, but rather multiple insults that cumulatively cause damage. And so I think that if we anticipate situations and can minimize in susceptible patients the introduction of nephrotoxic insults, that will reduce disease burden. And I think we need to identify early decrements in kidney function and optimize fluid status and withdrawal of nephrotoxins. And lastly, early nephrology evaluation. I put a question mark on there because there are mixed data as to whether early nephrology consultation even makes a difference, which is clearly not the case for cardiology. If a patient has an acute MI, the earlier we contact the cardiologist, the better they do. We're not even sure in nephrology, if you contact us early, whether that makes any difference. In nephrology, or at least in reference to acute kidney injury, a gram of prevention is clearly worth more than a kilogram of cure. Obrigado.